Well, welcome everybody, and thank you for tuning in today. I have the special privilege of being joined today by Dr. Samuel Lau and Dr. Gina Pritchard to discuss the importance of oral health care to overall systemic health and the importance which has been highlighted, especially during this pandemic. So we're going to touch upon the COVID-19 crisis. But before we go any further, by the way, I'm Steve Thorne, the president and CEO and founder of Pacific Dental Services. I'd like Dr. Pritchard and Dr. Lau to introduce themselves. So ladies first, Dr. Pritchard.
Thank you so much. I'm thrilled to be here today to discuss this most important topic and one of my favorite topics. As you said, Dr. Gina Pritchard, and I started out in the 1980s as a registered nurse, went on to receive my board certification as a nurse practitioner, and then ultimately my doctorate degree. And as I was rounding in the hospital and working in the critical care unit, the OR suite where we did bypass surgery, the the cath lab where we did stenting, I began year after year after year to be frustrated with the people that would come back for a second, third, and fourth heart attack, a second bypass surgery. And I can remember the day that we were all sitting in the break room and we had put the number 8 stent in the person's coronary arteries. Nowadays, we'll put in 10, 20, more than that over a person's lifetime. This was early on, and we're like, how many stents are we gonna put in somebody? And so I began to seek out what are other people doing, because while it's thrilling when you're in the throes of a heart attack that we can keep you from dying and we can get you back on the road to get back into your life, it's also horrifying when you send people home, either that do die prematurely, that don't get to go home, or you send people home and their life is never the same. So begin to seek out what are people doing to keep people out of the hospital the first time, but definitely the second and the third and fourth time. And that leads us to the oral systemic relationship, which we're talking about today.
Well, that's great. I can't wait to hear some more about all you've learned through the years. It's obviously a passion of mine, and that's how we connected. So great. And Dr. Lau, you've been at this a while. Periodontal, why don't you tell us about your history there?
Sure, Steve. And again, I want to thank Pacific Dental Services for allowing this very important thing to happen. I absolutely agree with Jenna. I am a periodontist, University of Florida College of Dentistry. Started the graduate program there, then got into some dental politics. I'm the former president of the American Academy of Periodontology, also became president of the Florida Dental Association, then went on to be a ADA trustee. I still practice, I still see patients, primarily with laser activity, because I don't feel you're credible unless you do practice when you're speaking to other practitioners. And so I do periodontal consulting. I work with companies like Vigilant, and just try to keep the agenda full.
Well, that's great. And started out, if I read right, started out at Pankey, right?
Yes, and still involved with Pankey.
Oh, okay, great.
It's geographics. We're very fortunate that we have both Dawson and Pankey in Florida. And it has just been one of my passions to be involved with the Institute, but also with Dr. Pankey's philosophy.
Well, let's start with a question for you, Dr. Lau, around just defining what oral systemic health is and how our periodontitis is related to so many other things that are happening. Then we'll jump over to you on the Dr. Pritchard on the MD side too. But let's start with you, Dr. Lau.
Yeah, and actually, when I do think it, I will rely on Gina quite a bit, because Steve, we were talking prior in our little warm up. It's very interesting about dentists and who we are and what we are. I've always said that given another time or place, wouldn't we be like medical specialists?
Yeah.
And it's only by politics. You remember this, Steve, when they used to say the people that went to dental school are those who couldn't get in medical school. Remember that?
Yeah, I remember that.
Yeah, and I looked around, and when we took courses with the med students, I said, I'm just about as smart as they are. And then I realized I was actually a lot smarter than they are, because I wasn't on I was working 40 hours a week instead of 100 hours a week and making just as much money. So, but there is, isn't there? There is a little bit of a schism amongst that. And I actually would like to, at one point when we finished, I will hear Gina speak about cardiologists and relationship, because I think we know, and you said, Steve, that I could say anything I wanted within reason. We oral health professionals know a heck of a lot more about medicine than the medical profession knows about dentistry. And yet I think we sort of think that anything above the neck, especially our hair, is supposed to be teeth. And I know that's what you're driving for, that not to happen. So if I go back historically, I'm not sure how it ever came about. I'll be biased. It really is the periosystemic link for the most part. I'll be okay and go along with the ADA and call it the oral systemic link.
Okay.
But most of it is the genesis of perio. And where did it all start? It started with the American Academy of Periodontology. And it started with us. We've got scars on our back when we went for the heart. And we went to the American Heart Association, which still will not completely agree that there's a direct relationship. We went to the journal, we went to cardiologists, went to Journal of Cardiology, and they actually did listen, and they did publish papers that demonstrated there was a direct link when you looked at odds ratios. And from there, it began to take on a life of its own. I want us at some point to also talk about, even though all of us know about it, how we're not moving it as quick as I want, you want, and Gina wants. I want to have that conversation because studies there actually is an international study we can talk about why dentists don't put this into their practice. And I think that is critical. So Gina?
Yeah, we'll talk. We'll hit on a couple of those things, and I'd love to get your opinion on a couple of those areas as we circle back to you in a minute. But Dr. Pritchard, it'd be really interesting. You mentioned something about the cardiologists and some of the studies. Well, we both follow some doctors, Dr. Brad Bale and Dr. Doneen, and some of their work, and they've published a study showing the causal relationship of some of the stuff that's going on in our mouths to cardiovascular disease. But I want to hear a little bit broader than that. The other areas also, dementia, preterm, low weight births, brain, diabetic health, and things like that around oral systemic health.
Absolutely. And I do think you mentioned COVID earlier, that this year, if nothing else, COVID has brought to light the fact that anything that insults the body, this year it happens to be that COVID is top of mind, but prior to that, it could have been the flu, it could have been TB, it could have been a whole host of things, a skin infection. If you also had this underlying altered microbiome in the oral area, periodontitis, or presence of these high-risk pathogens. So you mentioned this causal relationship. We have several studies outlining that physiology between these bacteria that are often implicated in periodontal disease that are directly correlated with atherosclerosis, vascular disease, heart disease, as you mentioned, low birth weight, or even, loss of the child, and problems with delivery. And dementia, for sure, Alzheimer's. So yes, Dr. Bradley Bale, Dr. Amy Doneen, even Dale Bredesen. I know that his RECODE protocol that's now going to be RECODE is out, RECODE 2.0, as a much broader understanding and brings to light this oral systemic relationship that's key. So any comorbidities, whether it's in the general population, you hear diabetes, absolutely. Hypertension, of course, if someone's a smoker, if someone has high cholesterol. But those comorbidities simply mean that your body is trying to arise to the occasion. You've got this constant battle going on inside the body. The body's trying to save your life, appropriately respond with the immune system, both at the artery wall level, at the heart level, at the oral cavity level, and sometimes it just gets overwhelmed. And we've seen that this year like never before. So any comorbidities that I can find, I and my colleagues, that we can reduce while at the same time collaborating with an oral healthcare specialist, you're golden. It's the only way that you and I can promise our patients they're well protected from these future catastrophic events.
So touch on that just, Ted. Then I want to come back to Dr. Lau. On, in your mind, is the oral healthcare provider critical to that overall health of your patients?
Absolutely, hands down, there is no way that I can provide the care for my patients without collaborating. I don't even use the word refer anymore. I'm not sending you over there to see what they think. No, we're going to talk about your case. They're going to do their thing. I'm going to do my thing, and we're going to come together and merge our treatment plan, because it takes both areas of specialty to fully protect a person. And I didn't speak that boldly back when you and I first met years ago, and I was starting to understand this connection. I like kind of went in with fear and trembling because of a whole lot of reasons, right? We get a lot of push. But once you understand the science, and then you start to see one patient, and then 5 patients, and then 10 patients that you know, and I've got great examples that you know, that periodontal disease or the issue that was going on in the mouth is the main driver of their heart attack or driver of their second and third and fourth step.
And for the audience, you're not a dentist, and you are that passionate about it.
Exactly.
That's
I've had
great.
too many patients that I was scratching my head until the dentist got involved. The oral healthcare specialist got involved. Then the case was solved.
So back to you, Dr. Lau. I'm with you that there's many dentists intellectually that get this connection, right? But it doesn't come out in practice. And we were talking about that a few minutes ago. Take hypertension. We know they just lowered the baselines for blood pressure. And how many patients actually get referred from dental offices for that? Or A1C, or other inflammatory markers that we might look at. You mentioned interleukin-6 and things like that. Why do you think dentists haven't put it into their normal everyday practice yet?
To be blunt, ROI.
Okay.
I have always 3 mission statements, being a Covey person. You want to provide the highest quality of care, you want to be happy doing it, and you got to make money.
Yep.
In that order, by the way. I am a disciple of Dr. Pankey.
Okay.
But it really comes down to time and money. And what we've not done well is, because I'm not going to throw the baby out with the bathwater saying that, what we've not done well is been succinct with what the message is. We've not been succinct on how to create the diagnostics and the risk factors. We've not been succinct to show how that will create, which I think, and agree with you, the most important part of what we should be doing is retention and sustainability of our practices. I am emphatic. If you ever say the word fix or treat around me in dentistry, I will probably put a dink against you. I only want to use the word manage. We have lost our way. We are diabetologists. We are cardiologists. We are rheumatologists. And when you think about that, I don't know of a diabetologist that says, you know, you're fixed. You know, you'll never get it again. But I do know one thing. When everyone has a behavior, it's not because of them. It's because of us. We haven't created the systematic approach to create what they can do to put it into the dental practice. And so I put the onus back on us. Mm-hmm. And I think that working together with you, Gina, and others, we can create that. I would also suggest the place where it's going to be created first is going to be in the group practice setting. And the reason is because this is the researcher in me. It's about the end. I'm not a good anecdotal guy. I think there's too much cognitive dissonance. A periodontist, you know this, we're the world's worst as far as when you ask us to do something, we say, is it a rhesus monkey or is it a squirrel monkey? I mean, that's who we are, your brother, right? I mean, that's who we are. So when you come back to me, what I want to know is how can I methodically put it into the practice and hit those 3 things: quality, happy, money. When you do that, you'll see adoption.
Well, let's talk about a couple jump straight to, we got to come back to COVID for a minute, in just a minute. But let's talk about those changes of behavior. I was reading on your website, and you talked on your website about the roughly 50% of periodontitis goes undetected, and then we had a little discussion about when they detect it. So how can we determine earlier, when at an earlier stage, when patients are going to be sensitive to periodontal disease, or more likely to get periodontal disease at an early stage? Is there a way we can find that out earlier now with the tools we have and the systems we have?
Well, and again, I know there will be dentists that are listening to this. Hygienists, I know that will applaud me, but I just wrote a paper because I have involvement in Florida Probe. I own part of the company. I just did a paper for a group up in Canada, and I did my research. And I'm not saying everyone that's listening into this, but we're running about 40 to 50% of dental practices who do a charting on a patient. Now, part of that could be what? The fact that charting is an onerous thing. I don't know anybody who wakes up in the morning and says, I just can't wait to go in there and do periodontal charting. I can't wait to pick up a spear and stab somebody 192 times. So there you've got that. And then if you start talking about attachment levels, just take a knife and stick it in my heart. So what I would like to see is that we're not going to change that, by the way. When we created automated, voice actuated probing, I thought it was going to be to make money. I learned that it wasn't. But what it was to do is to get hygienists and dentists doing periodontal charting. So you can't treat something, remember I said scan, plan, you can't treat something unless you look for it. Mm-hmm. And right now, it's difficult to look for it. And secondly, and I want to get, also I think Gina would love this one, is that when we see something, this, it's already happened.
Right.
And I know that's where you were going with this question.
Exactly.
Where what we want is to see something with minimal false positives, false negatives that tells us it's going to happen. And that, in my mind, is the area that I think is probably the most undermined area in periodontics, and that is risk.
You're speaking, from a professional in the dental world, love language of mine there. So how do we get to more predictive in dentistry? Because I come from a family of dentists, right? My grandfather was a dentist, Harvard graduate. My dad was a dentist. Two of my brothers are dentists. They're great at fixing things. And that's what they're taught. They fix things. But what I don't get is, why haven't we moved from trying to find out why we have to fix things? How do we get to a more of a predictive nature? I want to kick it back to you, Dr. Pritchard, because I think on the medical side, they're a little more progressive in finding problems early, especially in what you're doing, Doc. Not all specialties are, but in what you're working on, definitely more predictive and preventive in nature.
Yes, I think this topic is absolutely key, because not only our colleagues, but the public has this mentality that if I have chest pain, I'll go to the heart hospital and they'll put another stent in, and I'll go back to eating McDonald's and smoking because they've got great technology now. Right. But what we know to be true, if we had seen that individual 10, 20, 30, 40 years ago, there are clues, there are signs. So it's never too early, I say. It's never too late, but it's also never too early. I love our pediatric colleagues who are starting to look for atherosclerosis, vascular disease, high cholesterol, oral health issues earlier, and get those clues, even if it's not glaring and staring you in the face. So a lot of people use weird metrics to determine if they're healthy or not. Their waist size, and that's important, but how they look in the mirror, how much weights they can lift, or their clean eating, all of that's vitally important. I'm not negating that, but unless you look inside the mouth, unless you look inside the body, unless you test some blood, test some urine, test some things, you can't treat it, as Dr. Lau said, unless you look for it. And if you want to avoid disability, if you want to avoid devastation in your future, the earlier you look, the better. And finding someone that is going to look at these more obscure tests.
So tell us some of the details of some of those tests.
Yeah.
Well, I think you and I both know what they are, but the audience may not.
Absolutely. So we were just talking earlier before we started this session that everybody is kind of becoming familiar with C-reactive protein. Okay, great, that's an inflammatory marker, but it's really one of the worst tests we have. Right. Because a lot of things elevated. It's a very global, gross, broad marker of inflammation. So you can have that if you've cut yourself, or if you've just delivered a baby, I was saying earlier, or even if you're not sleeping well, your C-reactive protein can go up. So there's more specific tests. There's blood tests and urine tests, and they have long, weird names, but like interleukin-6, like myeloperoxidase, like plaque-2. Those two specifically tell us there's arterial inflammation. So I don't care if you're 16 or if you're 96, if I draw your blood and you have an elevated myeloperoxidase or plaque-2, we're getting your oral healthcare specialist on the phone. I'm going to treat the things I can see, but we have to get those markers down because an artery, a vessel in your body somewhere is inflamed. If it's in the heart, you could have a heart attack. If it's in the brain, you could have a stroke.
Perfect segue from what we're talking about here to jump to COVID with interleukin-6. So give us your thoughts on, because I've read a couple of studies. There's a great study by Dr. Victoria Sampson on the British Dental Journal about the relationship there. I don't know if you guys have seen that, but give me your thoughts on the relationship between interleukin-6, why people with periodontal disease are having a more difficult time with the COVID virus.
Yeah, is that for me or for Dr. Lau?
Well, you go first, since you brought up interleukin-6. And
yes, so I would love to hear Dr. Lau.
Yeah, I want to hear it too.
Sure. But absolutely, interleukin-6, when we have an elevation there, we know that for one, this person is either inflamed or pro-inflammatory in nature. The host, as we call it, the individual, is got a heightened response to something. And we have got to reduce that. Maybe they're walking around, eating fairly well, going to their job, sleeping fairly well, they're functioning, but you throw a little bit of a common cold in there, you put a skin infection in there, anything can throw them off more easily than someone that doesn't have an elevated interleukin-6. That's very much a, the public explanation, if you will. But yes, I do love the study that you alluded to. And unfortunately, the fact that COVID has brought this to light to say, just add credence to what we were saying earlier. If you don't look for things early on, then when something like a pandemic hits, you're hosed. You could very well be in big trouble because you didn't look for these markers early on. If we know them right now while you're healthy and you think you're fine, we can do something about it without you experiencing the sequela that you don't want.
Exactly. Dr. Lau, I want to hear your thoughts on this and maybe touch on some of the related oral rinses and things like that that are being put out there. Give the audience some of your knowledge here.
I want to go one step back though. Okay. Periodontal disease is not an infection. It's a chronic inflammatory disease. And until we accept that, then naturally the way you manage it is going to be different. You mentioned rinses. I always say if your plan is to make the mouth sterile, the only way I know is to put the patient's head in an autoclave. Those days are over. It's not kill 'em all, take no prisoners. We are essentially almost like gastroenterologists. You don't see a GI doc trying to clean out the gut anymore. And even though I have, as far as a conflict of interest, I do deal with an oral probiotic company, Probiora, and I'll tell you why. Because I know that is where this is going. It may not be them, but I know that's where this is going. And so when we talk about periodontal disease, I think we still have even some oral healthcare professionals that believe it's bacteria chewing on bone. That is not even close. The microbiome, we now know what's the oral microbiome. It's not just one organism. We now know that that's just the stimulus. That initiates it, but what perpetuates it is the host, and why I still go back to risk. And so therefore, I do believe that antimicrobial rinses, yes, why not? I do believe taking trays and putting stuff in there and hitting, why not? Because at least you undermine the initiation. But Steve, you and your whole family of dentists, haven't you seen a 95-year-old guy come in when you can't even see the teeth because of the calculus? You look at him, it starts bleeding. You can't wait. You're salivating to go after him with an ultrasonic. You get and look at the radiographs. The bone is within 2 millimeters of the CEJ. The bone is looking at the calculus and saying, "I had to fight, break me down." You ever seen those cases? I have. And as a periodontist, I see 40-year-old patients that come in that are fanatical. They couldn't have a cleaner mouth unless they married a periodontist. And they have 80–90% bone loss. Don't tell me this is about flossing. That's why my favorite is when you start creating bumper stickers that say floss or die, you know, I'm not sure that's realistic. My point is this. Isn't it time to start balancing the chronic inflammatory nature of diseases along with what stimulated them? Yeah. In my mind, COVID-19 is not a viral infection. I would like Gina to weigh in on this. In my mind, it is a cytokine storm. Right. You know what that's about? Right. And it is that which puts people in ICUs and they die. It is not this virus chewing on things. The reason I bring this up is not just academic. The reason I bring this up is it then goes into how do I manage it? Remember, scan, plan, manage. Yep. And so therefore, you know, we do need to maintain the oral health because that is part of the stimulus. But I still think we need to go back to risk. I'm sorry to go back to it. It's my passion. Whether it be, as you know, you probably are aware of something called Previsor out there. Previsor, and again, you get it free, so there's no conflict of interest here, but Previsor is so valid and so reliable and so many articles that have ever been written about it. And all you're doing is just, you're doing check, 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 check. And it's incredible to tell you who's going to be at risk and who's going to lose their teeth. And yet it's been out 20 plus years.
I know.
And what has happened to it? You know who jumped on it?
Who?
Third party.
Who? Which groups?
Delta of New England.
Okay.
You know? And they're very smart.
Yeah.
You know, if you go back and look at interleukin-6, who jumped on that? Delta of Michigan. It didn't go very far, but Delta of New England right now is using Previsor for its providers. And why are they doing that? Because I do believe in a way, they want what? The right care. You know, what is this all about? You don't want to overtreat, you don't want to undertreat. Mm-hmm. So what do we do in dentistry? We overtreat. The same thing is true in medicine though, right? There's no test that is a false negative. Any test in dentistry is a false positive, right?
Well, wouldn't you say in the periodontal area, we probably undertreat? Because you know, right?
We way undertreat.
Okay.
We way undertreat. I mean, if I were to do a SWOT analysis on perio, there are so many reasons why we don't manage perio. And I get sensitized when we say, well, it's those dentists. No, it's not just those dentists. It's the fact that we haven't created the system. And I'm just going to make an editorial comment. My AAP friends will really not like me. They'll probably impeach me for this. But we had an opportunity with that AAP classification system.
The new one.
Yes.
Okay.
We had an opportunity to literally make this to where there was a classification system that could be used by all of us. We were sort of right on the staging.
Okay.
That's the charting, right? Mm-hmm. You and I and Gina are both in line with the grading. First time they've actually put risk in there.
Right.
But my goodness, Steve, if you go and try to calculate that, you need a computer.
Well, come back to the risk, and I want to come back over the cytocones in a sec, Dr. Pritchard, but come back to the risk assessments. What could dentists be doing better earlier, and be as specific as you can? I'm a major fan of the improvement in the AAP guidelines that they did in 2017, now implementing. You know, I'm not so sure most dentists, I'm not so sure most dentists know they changed the guidelines. GP dentists, to be honest.
Most hygienists are.
But talk about those risk assessments, because there's some really basic changes of behavior that dentists could be doing right now. Because in most states, right, the dentist has to diagnose the periodontal disease. In most states, the hygienist is not allowed to do the diagnosis. There's some states, technically, under the rules, right, most dentists have to do the diagnosis.
You are not even supposed to, and offices are shocked when I talk to an audience and I say, you're not supposed to touch them with a rubber cup until you have something in the chart. Every state law says that. But I know how it works
in practice, but I get it.
You're a CEO of a large corporate dental practice. But the bottom line is that when we look back at why they're not doing it, again, there are so many impediments to doing that. I applaud the AAP. Don't get me wrong.
Good.
What did they do? They actually put in risk for the first time.
Right. Well, let's talk about that. What did they do?
One of my favorites. They actually put implant disease in there.
Okay.
And, we could have a whole nother webinar on implant disease.
But they also put in family history.
I love what they did. My point is, when I go into practices and I show them those guidelines, they sort of get the staging part. Okay. But when we go to the grading part, they said, Sam, do you know what we're trying to do now with everything everyone's asking of us, including the blood pressure? I know. But at the end of the day, remember, you have to have the highest quality care. You have to be happy doing it, and you have to make money.
But we can't dentists, even if there's some tests out there that dentists could use, well, I don't think they can use them now in this country, but there are tests out there in the world where they could get a grading, so to speak, right? Aren't there's tests out there? Otherwise, how would they do it right now?
There are in Europe.
Okay.
And there will be more, but I've been through 25 years of those tests.
Okay.
You have too. I told somebody this morning, I put more litmus paper in sulcus and put it in electrodes looking for numbers. And how come those companies never made it? My point is, and again, I have no conflict of interest. I'm going to go back to Previsor and why I love it. It takes about 1.5 minutes to do it. You don't even have to be in the patient's mouth, and you get a score from 0 to 5. And Steve, that's what we want.
Okay, so that's one thing they could be doing in a change of behavior. I'm passionate about the family history of any sort of chronic inflammatory diseases there.
That's in
because there's such a high correlation. I want to come back to you, Dr. Pritchard, about that in that area. There's just the amount of science that has been released in that area in the last decade is absolutely unreal.
Absolutely. And really what we're talking about is our genetics, right? I mean, we all come into this world with our DNA. And so family history of whatever it is, early onset dementia, heart attack, stroke, diabetes, etc., is a clue into what your genetics may hold. And so the body, as Dr. Lau has just described, is like a symphony. And as healthcare providers, oral and medical or systemic healthcare providers, if you will, we're trying to be the conductor and bring up the immune system appropriately and calm down any inflammatory response or any infection. And I agree with Dr. Lau when he talks about periodontal disease, periodontitis being an inflammatory, chronic inflammatory disease, not an infection. The same is true of vascular disease. But you and I sitting here feeling just fine have no clue how our chronic inflammatory vascular disease is doing right now, unless we look, right? So again, I don't even know if I'm answering your question,
No,
but bringing
are.
it back to COVID and the cytokine storm, et cetera, it's bringing to light what we're talking about here, that dental and medical or oral health care and systemic health care has to come together to look early on. And then even in the setting of a crisis, such as COVID-19 that brings about the cytokine storm. Right. If you come into the hospital or contract COVID with this periodontal inflammatory disease, with this vascular inflammatory disease and diabetes or even pre-diabetes or a little bit of insulin resistance, your body is trying to rev up the percussion section and calm down the harps or whatever it is. Bring the soldiers out, the white blood cells, the neutrophils to rise to the occasion appropriately while killing the bacterial infection. So really it's all about the microbiome environment and how that also bleeds over, no pun intended, into the vasculature.
But a new patient that comes to see you, mm-hmm. you do some, I'm gonna put you on the spot, you do some of these oral tests, right? Some of the genetic tests? Like which ones do you do? So,
and I didn't in the beginning. I did the blood tests and then called the oral healthcare specialist up on the phone and said, you know, what I'm seeing. And so I did start kind of with fear and trepidation, ordering some oral salivary diagnostic tests to look for interleukins, to look for bacteria, to look for some of these pathogens, mostly as an eye opener, because my job was either hard on the beginning to say, we're gonna call your dentist or your dental hygienist or your oral healthcare specialist, and they may say something like, well, I don't know about the inflammation and I don't know about their heart attack. They look pretty good. Dr. Lau was saying earlier, what the low percentage that are actually doing charting, et cetera. Well, I need more than pretty good. I mean, so I would say to the patient, you're going to keep your dentist. I know you've been with them for years, you love them, but you got to see a specialist, an oral healthcare specialist that can look a little deeper. So, but back to your question. So I do the bacterial testing simply to open the eyes of the patient, to say to them, I can't adequately treat this. So I want you to know from the beginning, we'll be collaborating with someone else, whether it's your current oral healthcare team or another one.
And the genetic testing, right?
And genetic testing, I do, absolutely, to look for heart attack risk. So like, I don't know if the listeners are familiar with like 9p21. Most people have heard of ApoE because of your increased risk, not only of premature cardiovascular disease and heart attack, but also Alzheimer's disease. Right. And the, epigenetics or the coaching that we can do to help you change your lifestyle and reduce that risk. KIF6, MTHFR to see if you're methylating those B vitamins. All of these things are part of this orchestration. So, I mean, I could list, 40 genetics, but there's about 20 I do in the beginning, and then we dig deeper knowing once we start to see what the problem is.
And for the dental audience, it would be primarily interleukin 6. Mm-hmm. And now we've seen that the correlation between interleukin, elevated interleukin 6 and difficulties with the coronavirus. Mm-hmm. And you would know that on your patients in advance.
Right. So those are, we would be much more vigilant about avoiding. And, even if they're 30 years old, we would give advice like we would an 80-year-old to say, you're at high risk. And we've got to make sure you're vigilant with your oral healthcare specialists and do some extra things.
That's exactly where I was going. We've got to get this idea that it's only age. Because I was coming back to what Dr. Lau was saying on the risk assessment. We don't have time to go through my whole history here too, but I've learned so much about myself in the last 5 years as I've grown in knowledge here too. But I'm a high risk patient, put it bluntly. I could go through all the details, but I wouldn't have known that if I didn't have all the tests done, because I work out every day. I work out for an hour almost every day. I eat healthy. I've got low BMI. From the outside, I look totally healthy. But on the inside, it wasn't as good as it looked from the outside. Put it nicely.
Yeah.
But
I love that example. I love that you put yourself out there, because there are millions of people just like you that say, I look pretty good, I'm working out, I'm eating pretty clean, I don't smoke, all of those things, but they're not really looking at the right things. They're not looking deep enough.
yeah, and so a change of behavior in the dental offices, I'm going to come back to you, Dr. Lau, would be maybe just a couple of tests that we're doing, and dentists aren't used to doing tests. They're used to looking and fixing, right? Aren't there a couple, right? Generally speaking.
Yeah, this is how we are very, very different from medicine. Medicine right now, when I see my internist, if there's anything wrong, he rarely ever touches me. He just sends me for a test. I'm not taking anything away from medicine, but generally that is the case.
Right.
Dentistry is not about diagnostics. It's not. Now, with the advent of, digital radiography to a certain degree, but we're not about diagnostics. And so, and again, to be perfectly blunt, we have to be looking at the payer side here, Steve.
Mm-hmm.
We cannot be in a bubble. I'm not in a bubble. I will promise you, I'm not in a silo. In medicine, they have payers for all the things that she's talking about.
Yeah.
That's not coming out of pocket for most folks. Maybe it is, but I doubt it. In dentistry, our payers do not pay for diagnostics.
So let's stay on that path for a minute. Right. So do you think we should combine medical and dental benefits under one and go to get away from the CDT coding system and get over to the medical? I mean,
well, I do know one thing.
Profession with its own coding system, right?
Well, I do know one thing, and we've talked about it because I was an ADA trustee in 2012, and I was up there at 211 East Chicago. We talked about it every month. We don't have diagnostic codes.
I know.
You want to hit it right between the eyes? We don't have diagnostic codes.
I was in the profession in the 90s, early 90s when they tried.
We talk about it every day. We do not have diagnostic codes, and without diagnostic codes, you gravitate towards treatment. Payers are going to pay treatment. They're not going to pay diagnostics. I sometimes do not understand why third parties would not be more in tune into pushing toward diagnostics, because my sense would be, from an actuary standpoint, they pay less. You know the numbers. If you look at 75% of payer reimbursement, it is on Prophy, bite wings, a D01150, and fluoride treatments. Yeah, it is kind of laughable, isn't it?
It is laughable.
Yeah. So then again, Perio, by the way, is a small little bar over there. Prophy's way, way, way up here. My point is to change behavior, you have to go, I think, to where the core is. And I'm with you. Diagnostic codes would really move us towards a much better direction. And, if we had, and we have a risk assessment code, but no one ever pays for it. Canberra has been out for years, but they don't pay for it. But if I put a risk code at $500 and I put a treatment code at $50, you know what I think would happen in dentistry? Things would completely change. Mm-hmm. I may be wrong. I'm not mercenary. I love my fellow man and woman, but I know motivators. You do too. When you go into these practices, I know the motivators. And I'll just one little twist. We thought, as periodontists in the American Academy of Perio, that we were going to find our salvation with cardiologists. We thought that we actually thought in our strategic plan that if we reached out to cardiologists and showed them the relationship, that they would actually refer patients to a periodontist. Because as Gina says, if I have a heart problem, I think I would probably go to a cardiologist. I don't know, or I'd go to Gina. But if I had a gum problem, Would I see a periodontist? Are you kidding me? No, I'd see a general dentist. The point is that my periodontist keeps saying, we're cardiologists. I said, no, you're not. And they said, why? And I always say, follow the money. If I refer to a cardiologist, why should they refer to me, except Gina? Unless they are what? Early adopters, innovators.
Right.
And that's what Gina is.
Right.
He's trying to grit. She and I both, we're trying to get into what? The early majority of the bell curve. But we're down here in that 6, 7, 8%.
Right.
I wish it was that high. We are, I cannot wait for the first major carrier to put it on record to come to us, come to Pacific Dental and say, we want to get away from the CDT coding system. We're going to do, it's just fees over the other side, over the one coding system. Do a diagnostic coding system, get it all right, do it in, physicians, you have what, 12,000 different codes or more now? Dentists, they have 600 or 700 codes. There's like, for one, I always use the example for dentists doing a crown because GPs, they make most of their money just doing a crown. For a porcelain crown, I think there's only still one code.
One code.
One code, that's it. And yeah, how many different porcelain
10 minutes or 1 hour.
Yeah.
It's one code.
Or you do it same day, or you do different materials or whatever. You and I are on the same page. So coming back to Dr. Pritchard, if you could reach out, and we talked earlier, you're building your business and you're continuing to grow in different states. How would you reach out to dentists near your practices to know that you're in it with them and want to help them build their practices and help people be healthier and happier? What would you do?
So I would call or try to have a conversation, a face-to-face, have one scheduled next Friday. I've had one this week with a potential new relationship with a oral health care specialist to say, I have patients that need your services, that I cannot fully do my job, meaning fully assure them they are protected with everything we have available to us today, technology, treatments, medications, tools, to whether you've had a heart attack or such as yourself, you're very healthy and you're young and you don't want to have a heart attack or don't want to have dementia early onset or otherwise, we've done everything we can do. I can only go so far. So I have patients to send you. And if you identify people, as you said earlier, that are high risk based on family history or based on what you're seeing in the mouth or based on airway issues, if we want to go there, would you consider referring them to me? Because I am wanting to merge our treatment plans and help us to both be more successful. Just getting that conversation is sometimes, a challenge, but you kind of, we've all been in this long enough that we kind of get word of mouth that so-and-so down the street or so-and-so 2 cities over or whatever is, the terms are all different, but are getting into whole body health, right? Or wants to learn about whole body health, etc. So we can all be more successful. And as Dr. Lau said, have the patient outcomes we want, have the type of practice we want, and have the income we want by working together.
And are you finding dentists around the country more receptive?
Yeah, so it's interesting.
Yeah.
I would say every year the conversation gets a little bit better and a little bit bigger and a little bit stronger, right? Which is so exciting for us all. But it is very similar to talking to the cardiologist, because every year there's 1 or 2 more that sends a patient over to me, and they do what they do and they're very good at it. If you have a heart attack, you want the person who is very good at understanding how to quickly treat you, right? Not just the cardiologist, but the whole team. So when we think about, then you leave the hospital, you're still going to see the cardiologist to keep from going back to that scenario again. That isn't really their area of specialty. They are great at acute care. And some of them are getting into, there are a few cardiologists that are getting into this prevention focused work to try to keep people out of the hospital. But I would say 90% of them are doing what they do. And that's what we want them to do. That's what they've been highly trained to do. And so the conversation with them oftentimes doesn't go very far. But then, you know, it's getting better and better, because then you can, much like talking to the dentist, you can be a problem solver for the cardiologist, because if they have one patient that comes in post-heart attack and says, what else can I do besides take this statin? Do I need to eat a certain diet, or do I need to, they can hand them my card. And I will not, I have nothing to say bad about them. I would sing their praises, because they knew that it wasn't their area, but there are people out there doing it. The same with dental and people like working together.
We're seeing the same thing on the patient side also in our network, that patients are starting to get it. And part of how I teach it is patients are getting it more and more, and they're going to get it more and more in the future. And if you don't get it, doc, you're going to be left behind. Would you say it's an accurate statement to say periodontal disease, endoabscesses, some of the other stuff that are probably near and dear to you to watch for as a primary care provider, are medical problems with dental solutions?
Absolutely. And sometimes I can suspect, or sometimes I can just say, I don't know, something is missing here. And so you need to see somebody that's going to dig deeper in the oral healthcare arena. But sometimes, yeah, I obviously feel strongly that that's what it is, but I can't treat it. You're exactly right. It's kind of why I went into doing oral bacterial testing with fear and trembling, because I knew I couldn't treat it. And it really wasn't even looking deep enough, but it was something to open the eyes of the patient, or they would keep coming back at 3 months and at 6 months and at 12. And I'd go, look, I know you've asked your dentist, I've called your dentist. They aren't interested in doing a little bit deeper dive. You've got to see somebody else. But when they see pathogens, or when they see, you know, it's the same as doing sleep tests or doing nitric oxide testing. It's like, if your dentist isn't into sleep or isn't into boosting nitric oxide, et cetera, you just got to see a specialist. I'm not saying leave your dentist, but we've got to have the right people on the team to truly save your life.
And Dr. Lau, what would you say, because some of the feedback I get from the dentists is they just don't want to look stupid in front of their patient on some of this stuff, right? They get it intellectually. They haven't invested to really learn it. It wasn't taught in school. There's not much CE around some of this stuff that we've talked about today. What would you say to these dentists that go, I know I should be doing it, but I'm not, because I don't want to look dumb in front of a patient?
And there probably is that segment out there. It's really, you know, again, I come from a family of educators. It really is about educating them, but doing it in a user-friendly manner. There are ways of doing that. I must tell you, our dental schools included, you know, especially some of the dental schools, like one in Arizona, AT Stills, no one leaves that dental school without knowing about the oral systemic link.
Oh, yeah.
If you look at Loma Linda, I mean, I'll just name schools. Loma Linda, for the last 40 years, has been very much involved in looking at patients, not looking at a class 2 restoration. So it really begins in dental schools. And so naturally, I think I'm going to get some cards and letters already from some folks, but now I'll get into academics. It was one of my passions. We have crammed so much into academics that probably has very little to do with what a practitioner does. You know this because you're having to retrain a significant number of practitioners. I already know that you're doing that. Not you personally, but anyone who manages a large group practice. So you ask yourself, what are they doing in those 4 years? Well, I must tell you, they are teaching the oral systemic link, but it is about translational. Everything that we do in the sciences needs to be translational. Do you remember dental materials? Yeah, you know, in dental materials, if it's not translational, I don't really care about the expansion of something. It has to be translational. So what we're doing, you and I, and there's probably, again, I go back to the effect that a large group practice can have on advancing dentistry. I really want to go back to this. If I, you know, and not saying that, you know, I would, you know, that I would tell you what to do, but you know PBRNs, practice-based research networks. You know what you have, Steve? You have an incredible practice-based research network.
Oh, yeah.
You and others who are leaders in this game have such a phenomenal possibility. Maybe that's why you're pushing this webinar. Phenomenal possibility to really move this thing forward, because it will not be the dental schools. It will not be the dental schools, because I know what we teach. I know we teach ethics. I know we teach all these things, but what happens when they get out in practice? You and I both know what it is. It's one of the cornerstones of education. It's called contingency management, and you cannot take away from that. Contingency management. If I want to teach oral systemic length, but I'm being pressured, or I'm pressuring myself to financially make a certain quota by the end of the day, I will tell you what's going to get caught in. So, you know, I'm starting to sound like a socialist. I hope.
Yeah, no, well, we see it.
But you know where I'm going with this. And there's one part that I also, when Gina mentioned about the microbial, there's one other part, I think, in all of this, though, that does become the closure. And that is, if I'm right. By the way, I just want to mention something. If anyone in the audience really wants to know about what happened in the revolution of periodontics, moving from infection to a chronic inflammatory disease, it is the 2008 Journal of Periodontology. You will see it. It is by Ginkgo. That changed everything. And by the way, that is, I think, free. That changed everything in what we think. So where I want to go with this, though, is, wait a minute. If we had antimicrobial on our head because we think everything is microbial, if I tell you it's chronic inflammatory, wouldn't you want your management now to at least balance out and be chronic inflammatory? Wouldn't you want, here's where I'm going with this, wouldn't you want, and I'm not wearing Birkenstocks, wouldn't you want, sorry, for those in California, wouldn't you want an anti-inflammatory?
Yeah.
Would you want an antimicrobial rinse? No, I think I would want an antimicrobial rinse, but also an anti-inflammatory. Where I'm going with this is polyphenols. Where I'm going with this is green tea. Where I'm going with this is some of these organizations that are like Periosciences that have created these antioxidant, anti-inflammatories. With you and your background telling us about your risk, I know I'll bet you're into anti-inflammatories. I may be wrong, but I bet you're wrong. I bet you take tons of
vitamins every day. I eat right. I got everything.
So my point is, shouldn't we begin to change the dynamics of moving towards an anti-inflammatory approach with what our patients do? Where I'm going with this is omega-3. Do you know there's studies in perio out there that really demonstrate the effects of omega-3 positively on perio? Wouldn't you want your patients that are especially high risk to be taking 81 milligrams of aspirin every single day, not for the coagulation, but for the anti-inflammatory effect? You see, that's where I'm going. How do I get my patients to do, listen, I bet you did too. I went through those smoking cessation programs, not that I was a smoker, but in my practice. Did you ever go through those things?
No.
I went through those smoking cessation programs with my patients. Do you know why we don't do smoking cessation programs with patients? It didn't work. It didn't work. So I just want to make sure, and I would like what Gina thinks about adding anti-inflammatory regimens from the environmental standpoint. If I've already got an epigenetic scenario with a sleeping dog, you know, what, besides the diagnostics, let's get into therapy. What would you do?
Yeah, absolutely. And we're talking about balance here. So it's not that we want to, be totally anti-inflammatory. We want the appropriate immune response, the appropriate stress response, if you will. So absolutely things like omega-3s, vitamin D, melatonin, zinc, quercetin, the list goes on and on. But again, changing the paradigm of the public to think there is this for that or a pill for that or whatever. If you're also 100 pounds overweight and not getting off the couch and not sleeping at night, etc., then you can take all of the vitamin D in the world, all of the omega-3 in the world, and you got to look inside and make sure that these things that you're doing, not only the anti-inflammatory or those things to support the appropriate immune stress response, are working, but that these other lifestyle factors are also working as well, and not just think they're working, but as Steve mentioned earlier, these tests to look inside and really assess, okay, this person, because of their ApoE status, maybe doesn't need quite that much omega, for example, and this one needs a little bit more based on their genetics, etc.
I know all about that one. I'm ApoE34, and
There
you
you
could
go.
probably tell me exactly what I need to be doing, but how many of the patients know that? Anyway,
Right.
let's wrap it up with this. We talked a little bit right at the beginning about relationship, because this is ultimately about a relationship between the different care providers. It's a relationship between the care providers and their patient ultimately, and keeping that patient at the center of this to help that patient be healthier over time. And we measure, and my belief is finding those providers, in my experience, finding those providers that do have this knowledge, like you do and others, and then sticking with them over time is so important. So we measure at our organization what we call CCX, which is continuing care. We don't call it recall, which is the old word in dentistry. We call it CCX for continuing care, long-term care. And it's all about creating a lasting relationship with that patient. Patients don't care how much you know until they know how much you care. And I think the same goes between providers, right? I'd like to hear maybe just some closing comments on this. You brought it up, Dr. Lau, earlier about the prescriptive part, but then also the relationship part between the dentist and their patients.
Well, even though we have significant information transfer with phones, I still believe there's a core that will never die, and that is trust and communication. And that comes with relationship building. Those practices and those DSOs that were able to come back after COVID-19 the strongest were those that continue to have the relationships with their patients during the off time. And those that didn't came back and had issues. So in my mind, the easiest way to get from A to B is to create that trust and communication. And the way you do that is through relationship. I would just suggest, though, that I'm into trying to create the relationship quicker between A and B than taking years. And I think when you manage that, then you're going to see the benefits of success with everything that we've talked about today.
Dr. Pritchard, over to you too. I think my guess is, and this is because we haven't known each other for a long time, but my guess is you probably don't lose very many patients from your practice.
That's right. Yes. And that's the key. I totally agree with you both that it's, for one, there's not a lot of us out there doing it. Like we said, more every year, but we need 10,000 more this year and 100,000 more next year of these relationships, not just me or you, but of the combined effort, right? But I think that building on what Dr. Lau said, one of the most important aspects is to bring, just as you did, Steve, your personal story to the table, both with your patients and with the community around you, because start with yourself and start having these conversations in the study club in a small group setting, but then also one-on-one about, and I can be a perfect example on the oral healthcare side, because this last year when we couldn't get in to see the dentist, I deteriorated from an oral health standpoint, and probably most of us did. I was doing the best I could do, right? So I can speak to my patients about that, and about I value that care as high as me getting an echocardiogram of your heart, or looking at your blood vessels, or getting these novel blood tests. I can only go so far, as I was saying. Right. So start with yourself. If anyone's listening, that hasn't had this type of collaborative care, if you can speak to your own experience, that says a lot. And then you can bring that to your presentations in the community and set yourself up really as a leader in your community.
I've done my story on stage a couple of times, and actually Dr. Bale gave my story on stage a couple of times too.
I love it.
It's interesting.
I'm going to have to go Google that. Is it on YouTube?
I don't know if it's on YouTube, but I'm sure Brad has it somewhere in his library. But anyway, I want to thank you both for joining me today. It's been a very stimulating conversation. I know we're all passionate about this area, passionate about creating healthier people and helping people be healthier, those that want to engage in this. we have the knowledge, we have the science, and we know what to do to help most patients out. And we've just got to keep pounding it. You said earlier with it, we just don't have enough people. But what I see happening is we may not be on the heel of the hockey stick. I'm a big hockey fan now here in Las Vegas, but we're on the foot. We're moving that way, and sooner or later we're going to get on the upper part of that hockey stick, and it's going to be rocking and rolling across the country. The science is clear as a bell to me. We don't need any more of that. We just have to get on the execution and implementation of it. So I want to thank you for all of that. We are going to be transitioning over to the live portion of the event, where Dr. Lowe and Dr. Pritchard will be answering some questions. So to all of you that are watching, I want to thank all of you, and please remember you'll be receiving a code for your CE at the end of this webinar. So with that, I'm going to turn it over to Kimberly, who will lead the next session of next segment of this presentation. So thank you very much.